Hi everyone, I've summarized the multiple sclerosis and pregnancy TOG article for you. I hope you'll find this summary useful, and if you do, don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. So MS is a chronic inflammatory condition in which there is demyelination of the central nervous system. It's a neurological condition that's characterized by relapses and frequently does progress, leading to neurological dysfunction and disability. It's 2 to 3 times more common in women than in men. Mean age of onset is 30 years. More than half of women with MS will develop this condition during the reproductive years. So knowing this condition and how it affects pregnancy is even more important. Prevalence among women is 285.8 per 100,000. Etiology is unknown. However, there is association with some genetic susceptibility to the disease. Lifetime risk is 1 in 330. 80% of people have an affected family member. Environmental or lifestyle risk factors, so viral infections like Epstein-Barr virus, smoking, and obesity all have their associations and their role in the disease. So there's three patterns of MS. So you have the relapsing remitting MS, secondary progressive MS, and primary progressive MS. 85% of people will have the relapsing remitting MS, where there's cycles of remission and relapse. Over time, some people will develop the secondary progressive MS, whereby relapses become infrequent but the disabilities worsen. 10 to 15% of people will have the primary progressive MS, where there is progressive worsening of disability from disease onset with rare occurrences of relapse. There's an expanded disability status scale, EDSS for short, which is used to monitor disease progression. It's a 20-point scale ranging from 0, which is normal, to 10, which is death caused by MS. There is fewer relapses in pregnancy. However, in the first 3 to 4 months postpartum, um, relapses can happen. Um, 20 to two, and this is the case in 20 to 30% of the female patients. The best predictor of postpartum relapse is pre-pregnancy relapse rate. MS relapses occur less often in Paris women, and pregnancy after MS onset is associated with a lower risk of progression. So it's a T cell mediated autoimmune disease. However, recently there's also a role of B cells in it. Therefore, there have been drugs that are now in the market which target these two type of immune cells. So in pregnancy, there's worsening of symptoms like fatigue, back pain, bladder and bowel problems. There's higher incidence of urinary tract infections, especially in patients who've got neurogenic bladder. Further reduction in mobility, increased spasticity as the pregnancy progresses, which is all associated with increasing weight and changes in the center of gravity. New symptoms, if they happen during pregnancy, then they need a prompt review by a neurologist. Women must be reassured there's no increased risk of relapse with the use of regional anesthesia, especially epidural, and breastfeeding has beneficial effects on MS relapse. So MS and pregnancy, so maternal effects, although fertility is not directly affected by the disease, the AMH levels, which are marker of ovarian reserve, have been found significantly reduced in women with MS. There's also higher frequency of voluntary childlessness. There's also 30 to 70% of women with MS experience some sort of sexual dysfunction. There is also the fear of disability, the fear of transmitting MS to the offspring, which again contributes to the voluntary childlessness. There's also increased rates of termination of pregnancy in women with MS compared to those without it. With fetal effects, there's no major increase in adverse outcomes. Rates of miscarriage, stillbirth, and congenital anomaly are not increased in women who have MS. There is the risk of fetal growth restriction is approximately 1.7 times higher. There's also increased rate of preterm delivery in women with disease manifestation. So, MS medications during pregnancy and breastfeeding, so all immunosuppressants and disease modifying drugs should be stopped prior to conception. Glatiramer acetate and interferons are safe during early pregnancy. The risk of stopping these drugs should be discussed in the pre pregnancy counseling, which should involve the neurologist and the MS nurse. The risk of relapse is reduced in pregnancy. In highly active disease, patients who are taking disease modifying drugs, there's a risk of significant rebound of disease activity within 3 months. So, some patients will then choose to stay on the drugs like natalizumab while pregnant, or alternatively restart it as early as possible in the postpartum period to reduce the risk of significant postpartum relapse. Other immunosuppressants and disease modifying drugs are contraindicated during pregnancy and breastfeeding, either because of their negative effect on the growing fetus or because of limited evidence of safety. So pre-pregnancy counseling, so you want to involve the MS clinical team, which includes the neurologist and the specialist nurses, meeting with obstetric team and helps in also reducing patient anxiety. Discuss risk of stopping the drugs during preconception counseling. MS is not a hereditary disease. The risk of having children who may develop the disease is very small. Risk of miscarriage, congenital malformation, and perinatal mortality is not affected. Advice to stop smoking. Cigarette smoke increases the risk of disease progression. So antenatally, you want to have an MDT approach to managing these patients, which involves the neurologist with an interest in MS and pregnancy, an MS specialist nurse, obstetrician with expertise in managing MS, a GP, and a community midwife. As pregnancy advances, pregnancy-related symptoms mimic MS exacerbations. So extra vigilance needs to be taken in order to assess these patients and their symptoms. Simple measures such as taking frequent rest and avoiding stress may be helpful to women with fatigue. Small dose of amitriptyline may help with neurogenic pain, and diazepam can improve spasticity to some extent. Bladder symptoms and neurogenic bladder patients should have monthly midstream urine samples taken because of the increased risk of urinary tract infections. In neurogenic bladder symptoms, now these may worsen with an increased need for intermittent self catheterization during pregnancy. Adequate hydration, high fiber diet, and laxatives all help to reduce the experience of constipation. Thromboprophylaxis with stockings and low molecular weight heparin is advised, especially for patients who have got reduced mobility or are wheelchair bound. Anesthetic review should take place where they can discuss pain relief options during labor and delivery. It's safe to use pethidine, nitrous oxide, and a transcutaneous electrical nerve stimulation machine and regional anesthesia during labor. Fetal scan surveillance is done for the third trimester as there is increased risk of small for gestation age baby. So relapse is more likely during first and second trimesters. MRI can confirm relapse and other pathology and is safe in all trimesters of pregnancy. MRI with gadolinium contrast should be avoided during pregnancy. Management of acute flare-up usually just involves oral or IV administered corticosteroids. This is safe during pregnancy and breastfeeding. Vigilance is required regarding maternal hypertension and gestational diabetes with repeated courses of steroids in pregnancy. Fetal growth scans, as said, during the third trimester. It's uncommon to be given steroids for more than 4 weeks before giving birth, but they will need additional oral doses or parenteral hydrocortisone during delivery and in the immediate postpartum period to lower the risk of acute adrenal crises. So for labor and delivery, so obstetric indications will indicate when the timing and the mode of delivery. Vaginal delivery is safe. Planned cesarean section may be an option for patients with severe neurological problems. Um, Patients who have higher disability scores may require induction of labor. The bladder should be emptied during labor and use of indwelling urinary catheter with epidural analgesia. So increased fatigue and maternal exhaustion, and if that happens, then they should be low threshold for assisted vaginal delivery. Postpartum in breastfeeding, the MS team should be involved. There should be a postnatal plan in the notes already. There should be vigilance for disease flare ups, advice regarding drug treatments and their implications on breastfeeding. The MS team should have given them contact numbers and follow up appointments. A written copy should be made available to the patient, the GP, and the obstetric team. Encouraged to breastfeed because of the benefits of breastfeeding to the baby. Contraceptive methods, most of them are safe. It's important to consider the woman's level of disability, mobility, and medication use when choosing the best contraceptive choice. So, in assisted reproductive techniques, the rate of relapse is higher following assisted reproductive techniques, higher after unsuccessful attempts and following GnRH agonists. Increased relapse rate 3 months following assisted reproductive techniques. Factors contributing to increased relapse rate include immunological changes during assisted reproductive techniques, increased levels of pro inflammatory cytokines, increased migration of immune cells through the blood brain barrier, stress, and discontinuation of disease modifying drugs prior to assisted reproductive techniques. So this is a table which it talks about clinical presentation of multiple sclerosis. So you've got primary symptoms, a direct result of damage to the myelin and the nerve fibers in the central nervous system. So you've got most common symptoms like fatigue, urinary incontinence, retention, numbness, tingling, prickling, loss of balance, dizziness and vertigo, visual symptoms like optic neuritis, diplopia, blurred vision, poor color vision, acute and chronic pain, constipation or anal incontinence, spasticity, cognitive symptoms, mood changes, significant clinical depression, mood swings, and irritability. Least common symptoms like dysarthria, dysphonia, dysphagia, seizures, tremors, breathing problems, itching, headache, and hearing loss. Secondary symptoms are complications as a result of primary symptoms, things like recurrent UTIs, poor postural alignment and trunk control, decreased bone density, and resulting in increased risk of fractures, shallow and inefficient breathing. So this is quite an important table because it talks about all these different drugs and whether and their safety of use during pregnancy and breastfeeding. So it talks about preconception period, pregnancy, breastfeeding, and then just general comments. So you can see that interferons and glatiramer acetate are contraindicated in the pregnancy along with teriflunomide and also your mituzumab. Okay, this is more medications that again the table goes through whether they're safe to be used during preconception, pregnancy, breastfeeding, and so forth. Well, thank you very much for watching and listening. I hope you found this video useful, and if you have, then please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already, and leave a comment if there's any topics that you'd like me to help you revise for your upcoming MRCOG exams.